Hi guys, my name is Giovanni Florence and I'm going to talk about Rivaroxaban in patients with heart failure, sinus rhythm and coronary disease. Definition: Rivaroxaban is an anticoagulant medication used to treat and prevent blood clots. Heart failure is a chronic, progressive condition in which the heart muscle is unable to pump enough blood to meet the body's needs for blood and oxygen. Heart failure is also associated with activation of thrombic-related pathways, which predicts a poor prognosis. About sinus rhythm is any cardiac rhythm in which the pulsation of the cardiac muscle begins at the sinus node. The coronary disease is an impedance or blockage of one or more arteries that supply blood to the heart, usually due to atherosclerosis.
The term heart failure can sound frightening, but it simply means that your heart can't pump blood as well as it should. Heart failure can be caused by a number of things, most commonly a heart attack, high blood pressure, problems with heart valves, or cardiomyopathy, a disease of the heart muscle. Joe has just been diagnosed with heart failure. Because his heart can't pump blood around his body as well as it should, it's causing symptoms into his body. When blood isn't flowing properly, it can lead to a build-up of fluid or congestion, a bit like a traffic jam. This fluid sometimes builds up in Joe's lungs, leaving him breathless. Fluid can also build up elsewhere in Joe's body. He notices this as weight gain and swelling in his feet, legs, lower back and abdomen. Joe also suffers from fatigue because his heart can't deliver enough oxygen-rich blood to his muscles. With your continued support, we're funding research to one day find a cure for heart failure. Right now, Joe uses medication to manage the symptoms and help him have a good quality of life. Joe has also made some lifestyle changes to help keep his heart healthy, such as quitting smoking, cutting down on alcohol and salt, staying active and keeping a healthy weight. Joe doesn't need any further treatments at the moment, but because heart failure can get worse over time, he may need them in the future. Some people are recommended to have a pacemaker or implantable cardioverter defibrillator, ICD, to help treat their heart failure. Joe spoke to his doctor about the impact his heart failure could have on his driving, getting car and travel insurance, and his work. His doctor has also recommended a cardiac rehabilitation program to help him get back to as full a life as possible. The program has improved Joe's energy and stamina and gave him the emotional support he needed when feeling low. This has helped Joe to continue different parts.
Application in medicine. The study hypothesized that treatment with Rivaroxaban, which is a factor X activated inhibitor, could reduce thromboid generation and improve outcomes for patients with worsening chronic heart failure and underlying coronary artery disease. In this double-blind randomized trial, 5,022 patients who had chronic heart failure, a left ventricular ejection fraction of 40% or less, coronary artery disease, and elevated plasma concentrations of natriuretic peptides, and who didn't have atrial fibrillation were randomly assigned to receive Rivaroxaban at a dose of 2.5 mg twice daily or placebo, in addition to standard care after treatment for episode of worsening heart failure. The primary efficacy outcome was a composite of death from any cause, myocardial infarction or stroke. The principal safety outcome was fatal bleeding into a critical space with a potential for causing permanent disability.
This was an analysis of the Commander HF study, which had been published just a few months ago. And what we did in this analysis was based on the results in Commander. We recognized that mortality was the main driver of the primary outcome of that study, and that many of the deaths were due to heart failure. However, thromboembolic events still continued in the Commander study, and we felt that there might be a signal for Rivaroxaban favorably affecting those thromboembolic events, so we decided to do a sub-analysis and look at that a little more closely, and that's the basis of what we did. So in the study, we used the commander population, and just as a reminder, these were all patients that had heart failure with reduced ejection fraction. They had chronic heart failure, but had experienced an episode of worsening and predominantly a heart failure hospitalization. And these were also patients that had evidence of coronary artery disease. They were in normal sinus rhythm, and they were then discharged from the hospital, and within 21 days of discharge they were enrolled in the study and randomized to receive either Rivaroxaban at a dose of 2.5 milligrams twice daily or placebo on top of standard care therapy, and then they were followed at regular intervals through the duration of
cons. About the pros, unfortunately in this population, rivaroxaban wasn't found to have a benefit with regard to the primary outcome. In the COMPASS trial in patients with stable atherosclerotic disease, the combination of rivaroxaban using 2.5 milligrams twice daily plus aspirin using 100 milligrams daily, but not rivaroxaban alone, was associated with a significantly lower rate of the composite outcome of cardiovascular mortality, stroke, or myocardial infarction than aspirin
Specifically, as we
alone.
know, COMPASS was a large multi-center, multinational trial which found that use of rivaroxaban, 2.5 milligrams twice a day, plus aspirin, was superior to aspirin alone in patients with chronic stable coronary artery disease for major adverse cardiac events, net clinical benefit, as well as mortality. In the sub-study, we looked at patients specifically with a clinical diagnosis of heart failure at baseline to see if they had similar effects. Indeed, what we showed is that according to the hazard ratios, the relative risk ratios were very consistent across the spectrum of whether or not the patients had heart failure or did not have heart failure. There was no significant interaction between those with or without heart failure, although interestingly we did see a significant improvement in absolute risk for those patients with heart failure. Patients with heart failure had an absolute risk reduction of use of rivaroxaban plus aspirin as compared to aspirin of 2.4%, with a number needed to treat of 42. This in comparison to patients without heart failure with an absolute risk reduction of 0.9 and a number needed to treat of 111. If we looked at the safety effects, that is major bleeding, we saw no significant difference between the patients that were treated with heart failure, although there were increases in patients treated with rivaroxaban plus aspirin as opposed to aspirin. Reduction.
About the cons, the primary efficacy outcome was a composite of death from any cause, myocardial infarction or stroke. Secondary efficacy outcomes included death from cardiovascular causes, rehospitalization for worsening heart failure, rehospitalization for cardiovascular events, and a composite of death from cardiovascular causes or hospitalization for worsening heart failure. Other efficacy outcomes included symptomatic deep vein thrombosis or pulmonary embolism. The principal safety outcome was the composite of fatal bleeding or bleeding into a critical space with a potential for causing permanent disability. Secondary safety outcomes included bleeding events requiring hospitalization and clinically over-major bleeding events. Issue applied in Ecuador. In one study, it was found that major and clinically relevant non-major bleeds were similar with rivaroxaban and warfarin, although intracellular bleeding rates were significantly lower with rivaroxaban. On the contrary, GI bleeding was significantly more frequent in the Rivaroxaban group.
Subsequently, new specific inhibitors of anticoagulant factors 10A or thrombin, such as dabigatran, Rivaroxaban, and apixaban, became available for the prevention of thromboembolism. Studies with dabigatran and apixaban in acute coronary syndromes have shown no clinical benefit for the prevention of recurrent ischemic events, yet both agents increased bleeding. The ATLAS ACS2 TIMI51 trial investigated the effect of Rivaroxaban in patients with recent acute coronary syndromes receiving current management that included both an early invasive strategy and dual antiplatelet therapy with aspirin and clopidogrel. The patients were followed for over 1 year. Rivaroxaban 2.5 milligrams twice daily reduced the combined endpoint of cardiovascular death, myocardial infarction, or stroke by 16%. Both cardiovascular and all-cause mortality were reduced 20%. Although major bleeding increased from 0.6 to 2.1% and intracranial hemorrhage from 0.2 to 0.6%, there was no increase in fatal bleeding.
And the conclusion is that in patients with recent worsening of chronic heart failure, reduced ejection fraction who also has underlying coronary artery disease, were known in trial fibrillation, low-dose Rivaroxaban added to guideline-based therapy was associated with a lower rate of the composite outcome of death from any cause, myocardial infarction, or stroke than placebo, nor did it favorably influence the rate of hospitalization for heart failure.
So with an average follow-up of just over 2 years, unfortunately we didn't show a significant impact on the primary endpoint, which was of all-cause mortality and non-fatal myocardial infarction or non-fatal stroke. Looking at that composite, the trial was very neutral for all-cause mortality, showed a very interesting trend in terms of reduction in non-fatal myocardial infarction, and showed a significant reduction in non-fatal stroke. Looking at the study in greater detail, it looks as though heart failure events were not influenced by Rivaroxaban, so heart failure hospitalization and deaths due to heart failure were very similar with Rivaroxaban versus placebo. The Commander HF result suggests that there is a benefit in the mild, chronic, stable patient from adding Rivaroxaban to aspirin.
Thank you so much. You have a great day.